Let me go to the first slide, please. So this is the message from me for you to take out today, is that for a spinal cord injury, I'm not talking about bone. I don't want my talk to be orthocentric. I like it to be neurocentric. So let's go inside the spinal canal. I like, if I have a spinal cord injury, and that happens within 200 milliseconds of trauma, and then the molecules and molecular things start to boil and start the secondary injury. And the secondary injury continues up to several weeks. And then you tell me, come back next year, I'll tell you where you're going to be. I like to change this concept that what if we have a biological marker that is not molecular, is not CSF, and you can see the pathology, you can see secondary injury, okay? So, and I think that's the holy grail, because remember, if you can look at the lesion and say, this is my secondary injury, and this is the quantity of my secondary injury, then the second question is that if I have a trial, molecular or whatever you want to do, hypothermia, decompression of Michael failings, then you could possibly have the effect of your trial within the first week of trauma. Because if you have the picture of your secondary injury on the MRI and you give medication, Viagra, to the patient, you should be able to see the effect on your molecules within the first week, and then you don't have to wait for about a year to see the outcome. So this is April. April was going to prom, and I cannot show my, it doesn't show.
Just talk about it.
I'm sorry, what?
Just show it with your fingers.
Okay. So April was going to prom, got involved in a motor vehicle accident, had a C5, C6, and C2 odontoid fracture and C5, C6 injury. And you see at 1 year from AIS grade A change into AIS motor 88, and she was able to drive a tractor. But we have to wait for. So thank you. So we had to. Now, if you look at this, if you look at, unfortunately, it's not seen very well, but there is a signal change over here between 5 and 6, and we reduced and fused, and this is the outcome of this patient. So, and in fact, this is the story of all the spinal cord injury patients. There is a normal recovery of function in spinal cord injuries. So if you are AIS A, B, or C, and you wait enough, and the studies of model systems of United States and also the MSCI of Europe, thousands of patients show that if you are AIS A, you have 25%, B 71%, and C 78% spontaneous recovery of function. So this is going to be difficult because if you have a treatment effect to have your power calculation for how many patients you would like to have AIS-B to see the effect of your medication, that's going to be essentially impossible. You need thousands of patients, and you know with the spinal cord injuries incidences that we have, it's going to be impossible. However, if we have a biological marker that we can see the same week, maybe we could have a more accurate determination of outcome instead of Asia motor score or AIS impairment scale. And this is the problem. No disrespect to orthopedic surgeons. For about 60 years, we have been looking at bone and morphology, starting from Nicole, Holsworth, Allen, Denny, Harris, White, and Punjabi, Vaccaro, and Vaccaro. So we see we have been looking at bone and we have not been looking at the spinal cord itself. However, MRI is the face of a spinal cord injury. So in other words, when somebody comes, if I come to your emergency department, I have a central cord syndrome, and if you don't have an MRI, you cannot say how soon I'm going to recover, because you have to wait for 6 months to a year. Now, this is what I'm talking about. So if you have a normal MRI versus you have an MRI which shows the lesion, there is evidence that the length of that lesion could be, I'm not saying 100%, it could be representative of secondary injury. So let's assume that your therapeutic trial medication stops the molecular cascade the night you use that medication. This is an MRI which is taken in about 50, 60 hours. If we use that medication immediately after traumatic brain injury, traumatic spinal cord injury, by definition, we should be able to see effect size immediately. So one of the problems is that we don't know how to define injury severity. And morphology is not going to show us injury severity. However, in my second talk, I'm going to give you some indication that the latest AO classification has some indication of what morphology does. So this is the way preclinical studies show. You have the kinetic energy, you use a specific amount of weight, height, and you get a specific lesion on the rat's spinal cord. And there are several, multiple studies that this is dependent on the severity of your injury. In other words, if you increase the weight of the drop weight of on the spinal cord, then you can produce a lesion which is measurable. That's one of the things. So if you can have a specific kinetic energy using a specific height and a specific weight, produce a specific length of lesion on your spinal cord in rats, which is shown that that's true, then why can't we do it in human being, the reverse transcription? In other words, if I have the length of lesion, can I learn about Dr. Chapman's injury severity? Or the vice versa is also true. If my length of lesion expresses injury severity, which is also true. So if your length of lesion on central cord syndrome is about 15 millimeters versus a C lesion with a length of lesion of 50, 60 millimeters, then we can learn what is the prognosis of those patients. And in fact, this is all over the literature. If you produce preclinical studies, if you produce a lesion in rats, within 12 minutes, you can see your lesion on the MRI. And there are many studies in the literature that shows that the lesion on the MRI is expressive of the injury severity. And in fact, if you go to Johns Hopkins, 1994, Perry Black showed it that if you have a strong MRIs, you can in fact measure injury severity on your MRI in vivo in preclinical animals. And he showed it by measuring the length of the... Now, if you go to human literature, you see that Dr. Osterholm at Jefferson, and this is the date 1989, he showed that in fact, I read the title for you, Magnetic Resonance Imaging of Acute Spinal Cord Trauma, Correlation with Severity of Neurological Injury. So even in 1989, we knew that there was a relationship between injury severity and trauma. So one of the problems that we are dealing with the literature also, Michael Felling has been pushing the point that decompression is good for a spinal cord injury. However, despite the fact that Michael Felling, Alex Vaccaro, and a number of other investigators showed that decompression helps or does not help recovery of function, but we never showed what kind of decompression. What do you mean by decompression? What kind of surgical intervention do you use to completely decompress the spinal cord? Okay, so if you have a C5, C2, 3, C4, 5 bilateral large facet, and you see the MRI and you see the lesion, you reduce and fuse. This is our classic teaching. Our classic teaching is that you reproduce your sagittal balance, align the vertebral bodies, fuse them, and as long as you reduce the fracture dislocation, that's decompression. That's not true, because look at this. If you look at this C5, C6 ACDF, after fusion, you see the spinal cord is not decompressed. So the question of decompression is all up in the air. What do we mean by decompression? And in fact, to show you that how much we are hypocrites, we have a bunch of huge investigators that they recommended in their protocols that we have to have preoperative MRI to make sure that we see the spinal cord compression, and when we decompress the spinal cord, that's going to cause recovery of function. But they never said what's going to show the postoperative MRI. What do we see in the postoperative MRI if there is decompression or not? So this is Alex, and this is the entire crew at Jefferson. And if you look at these bad boys, they have all reported that the length of lesion is representative of injury severity in human being. So the next phase of my talk is that from 2007 in Toronto, Michael Felling and myself, we presented 100 patients and measured the length of lesion in those 100 patients, and the length of lesion is expressive of your AIS grade. It's very interesting. For the first time, we know that if you have a biological marker that you can see, that could reflect your clinical status of the patient. And this is what Mianji found out, that if you have the length of lesion is directly related to AIS grade of the patient. And also Bolden in 2006 or 7, for the first time showed that if you have length of lesion, that length of lesion could express your neurological function and outcome. So for the first time, we know that if you look at your MRI and your MRI is normal and your patient is in coma with C5-6 unilateral rock facet, the prognosis is very good, according to all these papers. So, and we in 2011, we showed that in central cord syndrome, that if in central cord syndrome, if you measure the length of lesion, that was very, very precisely expressive of your Asia motor score outcome after 1 year. So remember that this is MRI within the first 3 or 4 days. The length of your lesion in the first 3 or 4 days can predict your outcome in 1 year. So, and you see that the length of lesion shows the manual dexterity, which is the main problem in patients with central cord syndrome. In central cord syndrome, you can easily have Asia motor score of 100 after 1 year. But if you ask these patients, how is your finger function? They say, shitty, because their fingers are very stiff. They can't use a keyboard. They can button their shirts, and that's called dexterity. Length of lesion in central cord syndrome directly was proportional not only to Asian motor score, but also to dexterity of function. So this is our latest thing that we did. We said at the University of Maryland, enough is enough. So this is a retrospective study of a prospectively collected data. We took 100 patients, and 100 is, trust me, 100 patients, AIS grade A, B, and C's, and following them for 6 months is not easy, okay? So in this 100 patients, we looked at the mechanism of injury, we looked at injury severity, AIS motor score, we looked at morphology of Jens, we looked at the effect of traction, we looked at the timing of decompression of Michael Fellings, we looked at methylprednisolone, we looked at surgical technique. Remember that this was one of our objectives. When you go to the operating room and you spend 6 hours, you reduce and fuse front and back, that doesn't mean decompression. We looked at our surgical techniques. What do we mean by decompression? And also, we looked at the hemorrhage inside the spinal cord, and we looked at the intramedullary length of lesion. Intramedullary length of lesion, this much versus this much, and versus this much in 100 patients, and we correlated everything with the best predictors. Now, it's interesting that our 100 patients, if you look at Marino's paper, AIS A 25%, B 71%, and C 78%. In our patients, across the board, decompression, no decompression, this technique, that technique doesn't make slightest bit of difference. 27% of our patients of AIS A improved one or more AIS grade beyond what they were at the time of admission. So if the patient was AIS grade A, became B or C, for example. If the patient was AIS grade B, converted to a C or D. If the patient was C, converted to a D or E. 78% were not. Very, very similar to the findings of Marino and the group. And this is what we found. Okay. Mechanism of injury, whether motorcycle or fall, age, injury morphology. I'm sorry, Dr. Chapman.
Okay.
So, steroids, timing of the compression. This is, Michael Felling doesn't like this slide because telling him that timing of the compression was a hoax is not going to like me. And for sure, Jim Harrop doesn't like me. And also surgical technique. So we found out that, in fact, surgical technique has no bearing on recovery of function. However, if you look at injury severity score, how bad the patient was at the time of admission AIS grade, bleeding in the epicenter of the spinal cord, extent of decompression. Remember that you have to prove that your decompression is complete. Extent of decompression expressed relationship with your recovery of function, admission AIS motor score, and intramedullary lesion length. Okay, so you have 1, 2, 3, 4, 5, 6 independent variables that tell you how the patient is going to do. If you have Asian motor score, you have to wait for 1 year. If you have AIS grade, you may wait for 1 year. If you look at the bleeding in the epicenter, you don't have to wait. If you have extent of decompression, you don't have to wait. If you have admission Asian motor score, you have to wait for 1 year. And if you have intramedullary lesion length, you don't have to wait for about a year. Now, so this is the result. If you put all those things in a regression model, multiple regression models, you find out that all the rest of those variables that they were important, they would go down the drain. They are hoax. The only thing which is expressive of your outcome as a biomarker, and that's precious because your biomarker could be there within the first week, is intramedullary lesion length. I think that's my last slide. So this is your intramedullary lesion length here and here and here. And read this very carefully. For every 10 millimeter increase in intramedullary lesion length, there is a 40% drop in the probability of AIS to rate conversion. So this is very clear that if you look at your patient, in the eyes of your patient, and he or she expects you to tell him, what are my chances, okay? If your lesion length on your MRI is 5 millimeter versus 15 millimeters versus 45 millimeter, you can easily say that what are your chances for recovery of function. And that's it. Thank you.